Hello class, this is Professor Streb, and today I'm going to go over care of the patient with fluid and electrolyte imbalances and care of the patient with acid base imbalances. Unit 4 covers chapters 11 and 12, the assessment of care of patients with the fluid imbalance and the ones with the acid base imbalance. The next slide, this is basically what your syllabus tells you to know. So make sure you're getting your syllabus and look at the page numbers and know exactly where they want you to read in the book. Fluid imbalances encompass a lot. You could have fluid volume deficit or you could have fluid volume overload. There are numerous health problems that can disrupt your body's fluid balance. Dehydration is probably the biggest one that we think about. It's the most common. And it's truly a serious fluid imbalance. If you don't have enough circulating volume, we'll call that hypokalemia, and that can cause workload of the heart to go up and just cause a multitude of problems. This can be caused by numerous things. Dehydration is typically caused by a lack of oral intake of fluids. Diuretics, such as Lasix, could also cause you to have insensible, just a lot of water loss. Vomiting and diarrhea are also common culprits that lead to dehydration. There are other multiple things you can think about, but fevers, burns, diabetes insipidus, we'll talk about that more when we get to the endocrine system. But dehydration manifests in a few different ways, and it's important to understand these because the disease process doesn't necessarily matter as much as understanding what, why or that somebody is dehydrated. So, a rapid weight loss, consistent thirst, vital signs. If you're hypovolemic, you'll be hypotensive, you'll have tachycardia, you'll have tachypnea as well, and you'll probably be febrile because you'll have a temperature because your body can't regulate its temperature because of that. When you're dehydrated, you'll have flat jugular veins. They will not be distended when you're laying at that 30-degree angle. Your mucous membranes will be dry as well. You'll have reduced skin turgor. And don't forget mental status changes, weakness, things of that nature. Make sure you understand labs. When you look at osmolality, we're talking about it's just more concentrated. The same with urine specific gravity. When you're dehydrated, your urine's more concentrated. You'll also see the BUN will go up as well. And that is a sign that you are dehydrated. It's also a sign that you might have some kidney malfunction. So if they're dehydrated, that's probably the cause of an elevated BUN. All right, so what do you need to know as a nurse? As a nurse, there's a lot of things you have to think about. You need to worry about I's and O's. Make sure that your patient is taking in enough fluid. The book talks about 2.5 liters of fluid in a 24-hour period, and making sure that the urine output is greater than 0.5 mLs per kilogram per hour. So it's not just that 30 mLs an hour, which is our standard and what we're looking for. But when somebody's dehydrated and we're trying to rehydrate them, this is just another way. Stable vital signs, we know that. Increases in weight. If you're dehydrated, we expect you to gain a half a pound to a pound a day. Just things to think about right through there. So when you're going to weigh your patient, make sure you weigh them every morning prior to eating. You want to be very consistent so you get a very accurate reading throughout their time in your care. And then make sure you're paying attention to their mental status. If their mental status is improving, it's probably indicative of them getting hydrated again. So that's a big key to understanding hydration and proper perfusion is that mental status. Interventions as nurses, you do have to do your assessments. Think about this though, when you're giving all this fluid because your patient is dehydrated, you also need to think about the flip side is if you're giving them all this fluid, you need to monitor for giving too much, where you could have fluid volume overload. It is possible to overcorrect. So you'd want to watch for some of those things. You'd want to watch the vital signs. You'd want to do your physical assessments. If your patient's laying down and they have distended neck veins, if you set them up to 30 degrees, those distended neck veins should go away. If they are overhydrated or they have fluid volume overload, you would see that as well. So make sure you're thinking about your patient in that aspect. Also the safety concerns of standing up too rapidly and getting orthostatic hypotension. Now we kind of continue with this. Fluids can be found in different places. The ones we talk about for the most part though, we talk about intercellular, meaning it's inside the cell. But when we think about our patients who might have fluid volume overload or things like that, we look about fluid that is intravascular, which is in your bloodstream. And if it gets too much pressure inside your vessels, it'll start to third space, and it goes to your interstitial areas, which will be just the area surrounding the cell. So it's kind of in the adipose tissue and the surrounding tissue, not the adipose itself, but the interstitial surrounding areas around the cells themselves. So make sure you just kind of take note of what that looks like. All right, fluid volume overload. This is just the opposite of dehydration. We call this hypervolemia, which is not really something we talk about. We don't use that word a lot, but it is hypervolemia. It just means that you have fluid volume excess and overload. This is exactly what I was talking about. When somebody has fluid volume overload, you expect to see some third spacing, which is when the fluid that's intravascular starts to seep out of the vasculature system and goes into the interstitial spaces. So the tissue surrounding your cells, and that's what causes that pitting edema. So just like I said, make sure you're looking for signs and symptoms associated with this. You can check the lung sounds, because we know if you have too much fluid volume, it'll go into it'll also do that third spacing in your lungs. It'll go from the intravascular area into the interstitial spaces, which would be your alveolar sacs, and then you would have that. You would have pitting edema. You'd have dyspnea while you're sitting there. You would have rapid respirations, trying to get more oxygen and gas exchange going on, weight gain. So it's kind of the same thing for both of these patients, the way you're going to monitor them, daily weights, etc. All right, electrolyte imbalances. We're going to talk about quite a few of them. The electrolytes are just the ions. They're either negative or positive. You know, we think about potassium, we think about calcium, magnesium, sodium. These are the ones that typically come to mind, and we're going to look at those a little more in depth. It's going to be important for you to understand a few things about each one of these. So when you're studying, make sure you know the lab values themselves first. It's hard to take an exam and do well on it when you don't know the lab values themselves. So if we're thinking about hyponatremia, you have to know that the normal volume, the normal levels is 135 to 145. So hyponatremia is less than 135. So if you were to see that on an exam question, your mind should go to, oh, hyponatremia. And you need to start thinking about a person who's hyponatremia. What kind of signs and symptoms might they have? How would I recognize hyponatremia in the patient? So if you don't have enough sodium, you think about sodium and fluid and how they kind of go together. If you don't have enough, you'll probably be dehydrated as well. It results in some certain things. So if you have less sodium, you're going to have a movement of fluid. So when we think about this, it's directly related to changes in fluid volume status, right? So sodium moves in the cell and potassium moves into the extracellular areas, which results in intracellular edema. So as you get this swelling, you could get swelling inside your brain as well with hyponatremia. And one of the big signs of that would be headache, this apprehension, anxiety, anxiousness. As the sodium continues to decrease and it gets lower and lower, you'll start seeing confusion, hallucinations, seizure, coma, and potentially even death. So that's why it's important for you to be able to recognize when the lab is too high or too low. It's not your job to fix it. You'll let the provider know, but you're the one who recognizes certain things. And it's important that you understand, you know, if you see this lab value, what would you expect to see in the patient? That's what we're trying to get you to understand. All right, hypernatremia is just the opposite. If it's over 145, that would be something that is problematic. We know that as your sodium levels get too high, it can be associated with higher mortality rates, and it's not a very common imbalance that we deal with a lot. But when we do, it's usually associated with water loss, like diarrhea, something like that, or you have too much sodium ingestion. But that watery diarrhea, if you lose all your water, you get something called dilutional hypernatremia. You might not have gained more sodium, but now that you have less water in your system, you have less volume, the amount of sodium compared to the amount of water becomes excessively high. So these are things we have to worry about, once again, monitoring the vital signs, lung sounds, body weight, things of that nature. All right, the next one we're going over here is hypokalemia. This is we're talking about potassium. Make sure you know your lab values. When we think about hypokalemia, we're looking at something that's less than 3.5. That's typically where most labs fall in with hypokalemia. It depends on where you work, but for Galen, make sure you're using your Galen lab values that are posted in Canvas. That'll always give you the best idea of where we're at. But NCLEX is not going to get real close. They're going to give you a pretty good difference, 3 or 2.9. It's going to be pretty obvious that there's some kind of problem. So think about patients who are at risk for developing hypokalemia. We think about people who are confused or restrained or malnourished because they're not getting the food they need. Some people who are on somebody who's on a diuretic, if it's a potassium wasting diuretic, that could cause you to have hypokalemia. There's other medications that can be there as well. So make sure you understand what some of the causes are, and not just basic causes, but understand why is it important. It's important for you to understand the medications because we give medications to patients all the time. So if they're taking steroids or digitalis or things of that nature, this too could cause you to have hypokalemia. Lasix is probably the most common cause of hypokalemia because it is a potassium wasting diuretic, and these patients who are on that medication will require supplements for sure. But make sure that you understand there are combination medications out there as well. I think about things that treat blood pressure, like hydrochlorothiazide. That has a potassium wasting diuretic effect as well. So you'd want to really kind of think about that if a patient is, on that. Make sure you're checking your patient. Hypokalemia could also cause the cardiac problems, right? It can lead to respiratory failure. It can cause hypoactive bowel sounds. There's a lot of problems that are associated with low potassium levels. So make sure when you're thinking about patient safety, you might need to hold certain medications. If your patient is already dizzy, if they have to get up and walk, you might want to, think about where you're at here, because hypokalemia can cause a lot of different issues. Make sure you're checking the apical pulse rate and the depth of respirations because of the potential for cardiac and respiratory problems. And before you ever give potassium, we talked about this in lab. When your patient has low potassium levels, you're going to have to give them replacement. And we typically give that via IV. But before you ever give IV potassium, you definitely want to check and make sure you have good vasculature access. You never want to have IV potassium, have an infiltrated IV and get into the surrounding tissue, because it can cause serious damage to that tissue. All right, the other side will be hyperkalemia. This is when it's typically above 5. That's where we're looking at here. So make sure if you see patients who are higher than that, your mind starts thinking about, oh, we have hyperkalemia going on. Patients with kidney failure are typically the ones we see in the hospital who have this problem more often than most others. So hyperkalemia is definitely associated with renal failure. Retention of potassium is why, if you're not micturating, your kidneys aren't working, you're going to retain that. So that is a problem. Also, if you have some kind of trauma or you have an excessive intake of potassium, this could also lead to hyperkalemia. So make sure you're out there paying attention. When it starts to creep up, it's very problematic. If your potassium level is less than 5.5, diuretics can be used to correct the imbalance. So if it's just slightly high, we can give a potassium wasting diuretic like Lasix, which is totally fine. That would be the intended side effect of that medication. But once it starts getting higher than that, 6 and above, that is something you're going to have to probably talk with your provider about to figure out what you're going to do, so you can be a little more aggressive in the therapy, maybe giving IV solutions, diuretics that way. But you definitely want to make sure you contact the provider, because if you don't, it can lead to fatal dysrhythmias in your patient who has hyperkalemia. We have calcium and magnesium will be the next two. When we think about calcium, for me, calcium is definitely associated with your parathyroid gland. So we'll kind of talk about that in a minute as well. So hypocalcemia, less than 4.5, you're just going to have to memorize lab values. There's no easy way around it. As long as you know the ballpark range, you're probably going to be okay. So we know with calcium, hypokalemia usually includes insufficient intakes of calcium or vitamin D. They go together. One helps absorb the other. So if you have a vitamin deficiency in either one, vitamin D could lead to hypokalemia as well. Or people who have parathyroid disease. And we'll kind of talk about that when we get the endocrine system as well. We know that a lot of clients don't really have issues, but it just kind of depends on, if they are mildly hypokalemic, not a real big issue. You can just take more food, eat oral calcium supplements with vitamin D supplements as well. You need to take it with milk for that absorption. So these are things that like NCLEX and ATI might kind of lead to more than us, but they do pop up on exams. So it's something to think about. When you are hypokalemic, you have this neuromuscular excitability. Your myocardial contractions are a lot less strong, so you get less cardiac output, and then severe muscle spasms. I'm sure you've all heard of the Chavusket sign, the monitoring for Chavustic, where you touch the side of the face on the muscle and it starts having a reaction. Or you can do the Trousseau sign, where you put on the blood pressure cup, and when you raise it above the normal blood pressure, it will cause you to have your hand do some flexion. So these are just things that we'll see more on ATI and NCLEX, I'm sure. Hypercalcemia can be problematic as well. This is typically if you have a client who has hyperparathyroidism. It's just producing too much, so greater than 5.5. What are we going to do about it? Think about patient education. There's not a lot we can do as nurses, but we do think about high calcium foods, trying to avoid those, trying to avoid foods that will increase uric acid and things like that. And you can see them listed here on the screen. All right, magnesium is just another one we think about. Magnesium can be hypo or hyper as well. This is the beauty of any of our electrolytes. They can be too high or too low, or just right in the middle. So hypomagnesium is less than the 1.5. It depends if we're talking about milliequivalents or deciliters. So it can be 1.5 milliequivalents per liter or 1.8 milligrams per deciliter. Just depends on what they're talking about. Either way, we know patients who are alcoholics or have heart disease, diabetes, things like that, can have hypomagnesium. Why do we care so much? Because when you don't have enough magnesium, it can cause you to have depression and confusion, but it can cause seizures. It also can just cause some very bad GI upset, nausea, anorexia as well. Hypermagnesium is one of the ones that I worry about more than the hypo. Yes, they're both bad. Don't get me wrong, because I don't want them to have seizures. But in my mind, when I start thinking about hypermagnesiumism, when it starts getting up high, normal range is up to 2.5, but when it gets 2 to 3 times that, and probably 2 times that, 1.5, 2 times up to like 4 or so, in my mind, these patients who have some kind of renal problem or excessive use of acids or laxatives, they can have some issues, or potassium sparing diuretics that kind of save too much. The problem with this is muscle weakness, and it's not just muscle weakness like in your arms. The muscle weakness in your respiratory efforts, as well as in your myocardial tissue. So these patients are often very sleepy. They're just kind of drowsy. They have a very weak pulse, bradycardic. That's a problem when we think about hypermagnesiumism. So make sure you understand, if you saw a patient who had a certain level of these electrolytes, your job is to understand that it's just that. This is the problem, and this is what I have to worry about. All right, acid base imbalances. This is one I did a whole lecture on, so please go back and watch the other lecture that I gave. It's in your supplemental stuff. It just says Mr. Streb's acid base imbalance, and it goes through how to determine if you're in acidosis versus alkalosis, and if it's metabolic versus respiratory, and then compensated versus uncompensated. So I'm not going to do that here, but this is just the basics. When you think about the acid-base balance, we're talking about a pH, which is your actual, the acid base, if you will, in your blood. A normal pH is 7.35 to 7.45. The lower that number goes, the more acidic it is. The higher that number goes, the more alkalytic it is. Acidosis occurs when we're less than 7.35, alkalosis above 7.45. So we already know this. What I want you to remember is that when we think about acids, I always think about carbon dioxide. Carbon dioxide is the acid that we're really talking about with these chemical buffers, and that's associated with respiratory. So when we're thinking about these patients, think of respiratory, CO2. And then we'll talk about bicarb as well on the next slide. It's kind of what we're talking about here though. So anytime that your CO2 levels start to increase, that is going to drop the pH balance and make it more acidic. So it's going to be up to you to understand that. When you look at a CO2 level, the normal level is 35 to 45. The higher your CO2 levels go up, the more acidic they become because it is an acid. The lower they go, the more alkalytic it is. So it's less, it's not more alkalytic or less alkalytic. CO2 is acid regardless, but the more acid you get there above 45, the more acidic your body is more likely to be. So, but we think about breathing. The less you breathe, if you have an obstructed airway, that's going to help you retain or make you retain CO2. So like our COPD patients and stuff are going to have a lot of acid buildup. Their CO2 levels are high, and that puts them in respiratory acidosis. Bicarb is something that the kidneys use, so metabolic or renal component. When we look at the ABGs, the bicarb or HCO3 is usually 22 to 26. Whatever the book says, whatever Galen's lab values are, that's fine. It's always going to be in that range somewhere. Each book has a different range. But when we think about what this means, as your bicarb goes up, it will increase the pH level, making it more alkalytic. As the bicarb goes down, it will decrease your pH, making it more acidic. So it's kind of it's different than respiratory. One of the biggest things that I think help more than anything else is when we talk about this is to think about Rome. Rome is something that we are going to talk about, meaning respiratory opposite, metabolic equal. And what that means to you is if your CO2 level goes up, your pH will go down, respiratory opposite. If your CO2 level goes down, your pH will go up, respiratory opposite. Metabolic is equal. If your bicarb goes up, your pH goes up. If your bicarb goes down, your pH goes down. So think about Rome, respiratory opposite, metabolic equal. It'll help you as you kind of go through. All right, give me 1 second. All right, there are 4 types of main imbalances: respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis. You are going to have to determine what your patient is in based on laboratory findings. When you think about respiratory acidosis, this results when you have a decrease in your pH, so you have too much acid in the body. It's typical to see respiratory acidosis in a patient who has respiratory depression. So if you just came back from like surgery and you had anesthesia on board and it caused you to breathe less, the less you breathe, the less CO2 you breathe out. That means you're retaining CO2. Airway obstruction, reduced alveolar capacity, right? So if you have fluid in the lungs, you have heart failure, you have a patient with COPD, these are all going to lend themselves to being respiratory acidosis because you cannot get enough air in to replace the CO2 in the alveoli on the hemoglobin, so it's going to lead to more respiratory acidosis. If you look on the bottom here, this is a prime example of what an ABG would look like for somebody in respiratory acidosis. You're going to have a low pH, meaning less than 7.35, and you're going to have a PCO2 or carbon dioxide level above 45. That means you have more acid in your body, so it makes you more acidic. That's how you're going to tell if it's respiratory acidosis or not. When you think about somebody in respiratory acidosis, it's very likely they might have hyperkalemia, meaning it's too high. So your patient might have signs and symptoms of, a weak decreased pulse, right? Because we already said when you start thinking about hyperkalemia, we worry about some weakness in some dysrhythmias that might occur as well. Like I said, just make sure you're looking at your patient. Make sure you're thinking about their vital signs. If your patient's not breathing adequately enough because they're a little depressed or they're asleep or they're unconscious or whatever the case may be, if they're not breathing adequate enough respirations, they're going to retain CO2, which is going to lead to respiratory acidosis. A patient with respiratory alkalosis, this is somebody who's probably breathing too fast. So if you are having, you're hyperventilating because you're having a panic attack or something like that, and you're breathing out all your CO2 too fast, as the CO2 levels go down, your pH will go up. So on a patient with respiratory alkalosis, you would see a pH of higher than 7.45, meaning alkalytic, and you would see a CO2 level less than 35, meaning there's less acid in the body. Metabolic acidosis is something that's caused as you lose too much of your base. So when I think about metabolic acidosis, it's an excess fluid a body fluid loss. Typically, if you had diarrhea, think about acidosis coming out of your rectum on the bottom part. So anytime you have diarrhea, think about your metabolic acidosis, right? Acidosis is associated with diarrhea or that loss of fluid from the GI tract. You can kind of see some of the other things going on here. A patient who is in renal failure, right? Who has the inability to pee. This also could, cause your patient to have metabolic acidosis. We have to worry about that as well. Renal failure lends itself to metabolic acidosis as well. Make sure you're able to identify what that looks like and what the causes may be. Metabolic alkalosis is the last one we talk about, and this is when you have too much acid loss. If you think about what causes this, I think about a patient who is vomiting, excess vomiting. If you're throwing up the acid in your stomach, that acid leaves your body, so it leaves too much of a base. So this is one where the patient, that's usually what I think about is this patient here. Why does this matter? Metabolic alkalosis can cause weakness of the muscles, right? So if I'm thinking about these patients, I just kind of curious about what could go wrong with my patient. So nursing management, monitoring for that acid base imbalance, like irritability, muscle weakness, muscle twitching, muscle cramps, muscle spasms. These are patients who have a lot of muscle weakness itself. All right. So make sure as you're going through your studies for Unit 4, you memorize what the lab values are. Make sure you know that range, and then understand some conditions that might lend themselves to this imbalance, and then be able to identify on your ABGs what your patient is presenting with, what some of the likely causes might be as well. That's all I have. I hope you have a great day.